Our next speaker is Brittany DeGreef. Brittany, some of you on the call might actually know Brittany or have seen her at the Cancer Center. She's a licensed certified genetic counselor, and she received her master's in genetic counseling from Northwestern University in 2016. And she is our lead genetic counselor at our NM's cancer genetics program. And she does provide comprehensive genetic services, counseling services. She coordinates medical management for patients and families that are impacted by hereditary cancers. Her goal is to help patients identify their risk status, including high risk, and their family members who might benefit from modifying some of the medical management. And this would include early screening and surveillance and different risk reduction strategies depending on what Brittany uncovers. So we welcome Brittany for our next update on cancer genetics. Thank you, Brittany. I think this is a good segue from this topic to your topic.
I very much agree. Thanks so much, Diane. I'm just going to go ahead and share my screen here. Well, thanks again for having me, everyone. I agree with you, Diane. I think this is a great segue, and everyone who presented before me really gave me the pleasure of easing some of my topics to talk about. If anyone has met with me or talked to a genetic counselor, I feel like we can talk about genetics all day. And everything related to cancer care recently tends to have a very strong genetic component while someone's being evaluated for what the type of treatment they should undergo, and of course, information for the family. I'm just going to go ahead and talk a little bit about what genetic counselors do and who we are. So we receive specialized training in medical genetics and psychosocial counseling. We're a pretty small group. So in the United States and in Canada, we have only about 4,000 genetic counselors, which is actually a pretty small group. We do receive our masters, as Diane mentioned, that I received. And then we do take a board certification exam through the American Board of Genetic Counseling. Many states do have licensure. Illinois is one of them, but not every state does. The benefits of that, of course, are to make sure that whoever's providing you genetic counseling is legally allowed to do so. So it's great that Illinois does have that. And then we do work in a variety of settings. So obviously we can work in any medical center, but also many genetic counselors do work in specific industry jobs, such as with a lab, or even specialized clinics, such as in neurology or cardiology, as an example. And so if you meet with a genetic counselor, usually patients ask, well, what does this appointment entail? And so we usually have appointments scheduled for an hour per patient we meet with. We ask lots of questions about your personal and family history. We take 3 generations. We provide a risk assessment based on personal and family history of cancer. We talk about if someone qualifies for genetic testing based on national guidelines. And then, of course, what are we thinking about for testing? Do we focus on a small group of genes? Do we look at a large group of genes, such as what we call a panel test, where we're looking at many genes at once? And then, of course, talking about the specific cancer syndrome we might be most concerned about. And then the other thing we also like to review is we provide anticipatory guidance. So if we do find something, what does this mean for you and what does this mean for the family? One thing that I think is different to our specialty compared to others is that the patient that's meeting with us, that's sitting right in front of us, of course, is our patient, but really the 3-generational pedigree or family history that we just took is our patient. So when we are meeting with patients and going through this information, we're of course getting information for every single person on that page and how our testing and those results might impact them. So we do then go through the different types of results. We also do consider other things such as insurance coverage. I'll talk about that because I know that is a big question with patients who meet with us, how long it takes for results to come back. And then afterwards, care coordination. So interpreting the results, there are many cases where we have gotten some complex results or incidental or unexpected results, which does take a little bit longer, and some follow-up is sometimes needed there. And then, of course, if we do identify a syndrome, we might not be talking about the specific cancer that patient might have that they originally met with us, but we also might be talking about what other risks that person is at risk for, what different clinics they should be screening at, and how often they should be screened, what relatives in the family should also be doing this testing, so on and so forth. And so to provide everyone with just a little bit of background about cancer genetics, I think a lot of individuals are surprised by this breakdown, but only about 5 to 10% in general is related to an inherited syndrome. And so this is where we can find a specific gene mutation or variant that's running through every generation in the family that might be increasing someone's risk. And I'll talk a little bit further about what gene mutation or variant actually means. I know we've heard that talked about a little bit before. Gene variants within a cancer is different than a gene variant that's running through a family. This is where we can see a significant increased cancer risk over the general population. Examples of this that many of you might know about are the BRCA variants, BRCA1 and 2, or something like Lynch syndrome. And then when we think about the other breakdown of cancer, about 70% of cancers in general is just a sporadic chance. And so we think about those as general population risks, maybe related to environment or things we just can't explain. So for example, breast cancer is an example just because it's common, but 1 out of 8 women have a 12% risk to develop breast cancer in their lifetime. Colon cancer is about 4.2% in the general population. Prostate cancer is about 11%. So just to give you some ideas of more of the common cancers. And then there's this other category called familial risk. And this is where we might see clustering of cancer on one side of the family. We assume it's due to maybe some shared genetic and environmental factors that are at play. We don't know what all of those are, so we can't test for those, but that's where we might see a slightly increased risk of certain cancers based on family history. So an example of this is I meet with a son, dad had colon cancer at some point in his lifetime. And so the son's general population risk is not that 4.2% risk I mentioned before, which is average, but since there's a first degree relative or a dad with colon cancer, their risk is about double. So that would be about 9% risk. And so this is just a breakdown of examples of some cancer types and the likelihood that we would identify an inherited syndrome. So again, if we think of the more common cancers, colon cancer and breast cancer, I'm not sure if you can see my arrow here, but about 5 to 10% of breast cancer is inherited. Triple negative has a slightly higher component. Colon cancer about 5 to 10. But if we get to more rare types of cancers, we can see ovarian cancer, specifically papillary serous or endometrioid, specific types of ovarian cancer, about 20% are inherited. And very rare tumors that pheochromocytoma or a paraganglioma, those are mouthfuls. Those are specific tumors that can grow in the body. They may or may not release hormones, specifically the fight or flight hormones. About 40% of the time, those tumors are actually related to an inherited syndrome. And so this slide here just highlights how, depending on the specific cancer we're talking about, whether you have a personal or family history of it, there might be a chance that that could be related to an inherited syndrome. Or again, in the most likely scenario, it's actually not related to an inherited syndrome based on what the family looks like. And here's just a nice slide, I think, that shows how in the general population risk, we see the risks lower. And then as we find these high risk genes, that might change. So this slide just shows that if there's a general population risk, you're on the bottom left of the slide. If there's a family history risk, it's slightly higher. And then the groups of genes that we think about testing for, there are the high risk genes where we know that there's a significantly increased risk over the general population. And what we've learned is that there's these new genes called moderate risk genes, where someone might have a slightly higher risk over the family history risk that they know about, but it's not as high as those high risk genes like BRCA. And so when are we most suspicious of finding an inherited syndrome in the family? We tend to see young ages of onset. So for example, ovarian and pancreatic cancer diagnosed under age 60, breast cancer under 45, colon and uterine under age 50. We look to see is multiple generations affected with the same cancer or related cancers. Does an individual have more than one cancer? So highlighted here is bilateral breast cancer, or someone who has both breast and ovarian cancer, someone who has ovarian and uterine cancer. And then also highlighted here are the same related cancers, and then rare tumors. So medullary thyroid cancer is more rare. Again, I already talked about the paraganglioma and the pheochromocytoma. Male breast cancer is very rare. So of course, any of those are, they are red flags, where we would be most suspicious of identifying something in a family. And then of course, certain ethnic groups like Ashkenazi Jewish ancestry, that just has a slightly higher chance that they have an inherited syndrome in the family. This was already talked about, so I don't necessarily have to go through all of this again, but just to review, everyone has cells in their body. And then as we get older and we're exposed to different things, there are changes or mutations or variants that occur over time. And this is what could lead to a cancer developing. At the bottom line, when someone has an inherited syndrome, they're kind of predisposed. So they are already at a slightly higher risk over the general population. And so it takes less changes over time to lead to a cancer. And this is really gets to how these genes are inherited and what they do. So the first presentation talked about tumor suppressor genes and oncogenes, which is important because what our genes are normally supposed to do is tell our bodies how to work. They tell our bodies how to grow and develop. They tell us what eye color we should have, what our hair looks like, the color of our hair, color of our skin, how tall we're going to be. These genes in particular are telling our bodies, let's prevent cancer from growing. And so they are all inherited in an autosomal dominant way. Many patients ask me, well, this only comes from mom, right? That's actually not true. Autosomal means it's carried by both men and women. Dominant means it only takes one copy of that gene not to be working in order to increase the risk of certain cancers. So if you think back to your high school and college biology classes and you did those Punnett squares with a big A and little a, you probably never thought that you would use that again, but here we are talking about a real life application. So what that means is that if both men and women carry these genes and we all have two copies that we get from mom and dad, our genetic testing is trying to see if both copies of those genes are working or not. Individuals usually ask me, well, I have the gene, or my friend has the gene, or I don't have the gene. That's actually not true. It's actually whether those genes are working like they're supposed to or not. And so when we identify someone on a genetic test that has a positive result, that means one copy is not working. There's a 50% chance it's passed on to future generations, but a 50% chance that it's not. These usually do not skip generations. I didn't put this on a slide, but in rare instances, there can be recessive conditions. And what that means is they're inherited in a different way. There might not be a strong family history, but it actually takes two copies of that gene not to be working in order to have the condition. And then in some cases, there are just random spontaneous changes that it happens in that individual. And it wasn't actually inherited from mom or dad. That might mean that it was a brand new change that happened in you. You could pass it on to future generations, but mom and dad might not have it. And that's why it's important to include a genetic counselor in this evaluation, pre-test and post-test, to help clarify these questions as they come up. I've already reviewed the positive type of result here, but there's also these other types of results. So negative versus an uninformative negative, and a true negative, and an inconclusive result. So a negative result means that we meet with the patient, they have a history of cancer. So I'll go back to the example I mentioned at the beginning. Dad has colon cancer. Let's say he was diagnosed at 45. Dad did genetic testing for a colon panel, meaning we looked at a group of genes related to colon cancer. All of those came back completely negative. What that means is we don't know why he got colon cancer at 45. And so nothing was identified on his test. Versus an uninformative negative. Uninformative negative means that I met with the son whose dad had colon cancer at 45. I did testing for the son, the same test I would have done for dad, but maybe dad is unwilling to do testing or he's already passed away. The son does genetic testing that's negative. And what I don't know about his negative test result is that, is he negative because dad had something, but he did not pass it on to his son who I tested, and that's why he's negative? Or is he negative because dad never had anything to pass on in the first place? And so that's why he's uninformative, because he doesn't tell me anything about the family history. True negative is the best case scenario for unaffected people. And what I mean by that is that there's cancer in a family. Someone who's had cancer is identified to have a syndrome. So again, we can use that example of dad and the son. Dad has something like Lynch syndrome, which is one of the more common causes of inherited colon cancer. So dad has Lynch syndrome. I test the son and he's negative. That means that that son did not inherit what causes dad's colon cancer. He returns back to general population risk. And so that's the best case scenario for unaffected individuals in the family. And then of course, we can get an inconclusive type result. Inconclusive means there's a change in one of these genes, but it's unclear if that change is causing the gene to stop working, meaning it is associated with an increased risk of certain cancers, or if that change is just what makes you and I different from each other, and it actually has nothing to do with cancer risk. Those types of results are usually downgraded in the future. They estimate about 80 to 90% of the time, depending on your ancestry. Those might get downgraded in the future. And so those types of results are treated like they're negative. We don't ignore them. We just kind of put them to the side. Your genetic counselor usually recommends you stay in touch with us. And then eventually the lab will reclassify it, and we would reach out to you about any new information once that's available. That's usually not a recommendation for relatives to do genetic testing. And there's really no reason to repeat testing, because it's not that we expect it to change. It's just a lack of information at that point in time. And so the benefits of genetic testing. Of course, it could provide an explanation for your personal and family history of cancer. It also lets us know what is your risk to develop a future cancer. So it doesn't necessarily tell us, will this cancer come back or will it recur? It lets us know if you're at risk for a brand new cancer or a cancer in a different part of your body. So then, of course, what that means is if that's true, let's go ahead and make sure we're screening that other part of your body and doing that screening maybe more frequently if we need to. And then, of course, what we heard from the first presentation with precision medicine is the potential use of other chemotherapy options you might not have qualified for if we didn't do the genetic testing. And this was something that has, become more readily available, which is great, because in the past, it used to only be, let's get information for the family. So it's helpful to know that the individuals who have a history of cancer, it's of course, there's a possibility that it actually might change your treatment course. And then, of course, identifying other at-risk relatives. So I have many patients who I meet with who tell me, I really want to do this testing for my children because I want to make sure that they're healthy. So of course, that's a recommendation that we might have for them based on their results. And then, of course, it's always changing and evolving. I am a forever student. I am always going to keep learning about genetics because it changes so quickly. There's new guidelines that come out all the time. There's new papers that come out. So it's always worthwhile to make sure you continually check in with genetics. And then the drawbacks. So will these results make a difference in my care? Unfortunately, not always. And so some individuals might choose not to proceed with testing because of that. The inconclusive results, as we talked about. So some patients say, that makes me feel uncomfortable. You might get an inconclusive result. I'm going to think about it, and you're not going to act on it, and that's really going to bother me. So I actually would prefer not to know that information. Alternatively, many patients say, you know what, I would rather know about that information if it's going to be there, so let's proceed with testing. And then, of course, the risk for developing cancer is not always established. As I mentioned, there's new genes being added to our panels all the time. They might have preliminary association with certain cancers. They might have a questionable association with certain cancers, but it's more of a data point. So some individuals say, you know what, I actually don't want to do a large panel test like that because I actually want to be more precise with understanding my risk. Are there interventions available, which kind of get at what I just reviewed? Psychosocial implications. Of course, this is a big one. Doing this testing doesn't only impact you, it impacts your family. And so that's something to think about. I have many patients tell me, I don't want to think about passing it on to my children. I would rather not know that information. Some patients think, well, my cousin on this side of the family had an inherited syndrome, but I'm not telling my parents I'm doing genetic testing. So that when I speak with them, I say, well, if we do your testing and you're positive, and it's the same variant that's in the family, I'm automatically going to know about your dad and your aunt's status. Are you okay with that? And then, of course, is it expensive? So this is a question we get very often before and during and after our appointments. Historically, it was very expensive, but it's not at present. There's still a cost, of course, but it's a lot less than what it used to be. So there's typically two charges. This is at least specific to Northwestern. It might be different at other institutions, but there's one charge for genetic counseling, which is billed like a regular doctor's visit, and then one for genetic testing. The one for genetic testing is usually billed through your insurance. Of course, your genetic counselor would talk to you about whether you met criteria or not, which of course helps us know if we should go through the insurance billing route. If we go through the insurance billing route, they usually look at unmet deductibles and copays for the year. Any cost greater than $100, the lab usually reaches out to you, lets you know what that cost is, and then you can kind of make a decision from there. There is also a self-pay pricing when you don't even use insurance. It's just a flat fee, and that's $250. You pay the lab directly. And so, of course, $250 is still a cost, but in the scheme of things, that is the most you would ever pay for genetic testing. And when I say genetic testing, I am talking about the inherited genetic testing. So this kind of gets to the next slide and things that we've already reviewed. So just a refresher, there is lots of genetic testing that's available when it comes to cancer. A genetic counselor is focused on the inherited genetic testing, information through the family, information present in every single cell in your body. And so next generation sequencing is the NGS. I heard that term used in a question. And so this is what the genetic testing of the tumor or cancer is called somatic testing. And that's when they're looking at many, many genes. And it's only looking at the cancer cells and the tumor only. It is not looking at the inherited genetic testing where it's present in every single cell of your body. So again, that's focused more on the treatment. However, we are usually looped in when there is that type of testing done, and there's a specific finding based on certain characteristics of that variant, based on the percentage of it and clinical information, meaning the type of cancer and what the family history looks like, where it might let us know, is that actually an inherited change that was just incidentally found in that test? And so then we might be called to evaluate that further. And this is just a picture to show that. So the genetic testing that I'm talking about on the right side is the inherited information, where we're kind of looking at the beginning. Whereas the tumor testing is looking at the end result and going backwards. So other considerations with inherited genetic testing, there's something called the Genetics Information Non-Discrimination Act, or GINA. This is a federal law that makes it illegal for health insurance and employment discrimination based on genetic testing results. It was passed in 2008. I'll talk more about that in just a minute. There are also family planning options and reproductive risk implications. So what we've also learned, as I mentioned, I'm a forever student, there are certain cancer syndromes that could run in a family that actually might pose reproductive risk implications. So an example of that is a inherited syndrome associated with a gene called ATM, like where you take money out of a bank. Now, an individual who carries that specific gene variant in their family, women are usually at a higher risk of breast cancer. There's a preliminary association with pancreatic cancer in some families, not all. There might be a risk of prostate cancer, might be a risk of ovarian cancer. However, if that individual and their partner, both of them carry an ATM variant, and then they have a child, there's a 25% chance that child could have a condition called ataxia-telangiectasia. And so genetic counselors also give patients and families that information to not only stand their cancer risk, but if there's a completely different syndrome you can have in the family for children. And then, of course, the openness or willingness to communicate with family members. I know in my family, not everyone talks to each other. I know not everyone's forthcoming to this. I know when you meet with families on holidays, the first thing you sit down and say, so tell me about your medical history. What did you find in your colonoscopy recently? Are you getting your mammograms? Some families are like that. Not all families are like that. So I think that that's also sometimes a barrier, sometimes a challenge. Just something to keep in mind when we meet with patients is that the family dynamics definitely impacts how this information is shared among relatives. And we hopefully can help provide some help with that with this family letter. And I'll show you an example in just a moment. And then, of course, the psychosocial implications that I already talked about, and patient advocacy groups. So when we do find an inherited syndrome, genetic counselors usually know about all of the support groups that are specific to that inherited syndrome, or different general groups that we can point you to, where you might feel like I'm the only one who's ever heard of this or been diagnosed with this syndrome. We likely can find other support groups that also have patients with that syndrome. So a little bit more about the GINA law. So again, it's a federal law passed in 2008. It is separate from the Affordable Care Act and pre-existing conditions. So again, it prevents and makes it illegal health insurance discrimination. So it is illegal to increase premiums, deny you health insurance coverage. It is also true if you switched in companies, they cannot use that information against you. It's also illegal for employment discrimination. So you can't be fired from your job based on this. You also can be not hired if you're looking for a new job. The exceptions to this: life insurance, long-term care, disability policies, companies that have fewer than 15 and 20 employees, military insurance. So in thinking of those life insurance, long-term care, disability policies, what that means is anything you currently have in place should be fine. But let's say you're going to open up something new and they say, can you please sign this release form that says we can access your medical record? They actually might learn about this information and say, well, we learned about your genetic test result, so we're actually going to go ahead and modify what we're giving you. And so now we're going to say you owe XYZ for your premiums, or we're not going to cover you at all. And so it's just something that we let patients know about. There's never a guarantee something like that would happen. There's just nothing preventing them from saying they can't ask about that information. And then there's a website on the screen there in case you were interested in learning more about it. There is also an Illinois specific law called JIPA, the Genetic Illinois Privacy Act. This is more surrounding employment discrimination. You actually have to provide written consent for if you did direct-to-consumer testing. I'll talk about that in just a minute, where your employer actually has to have written permission from you if they needed to get that information for whatever reason. And here's an example of a family letter. So we write this and it's written in this way where there's no names included on it at all. We just say, dear family, I am writing this. You can sign it, make it customizable. You also can leave it plain. I had genetic testing. I was diagnosed with this syndrome. This is the associated risks. It might affect you. Please go ahead and consider genetic testing. Bring this to your doctor. And then your doctor or genetic counselor can take this family letter. They can go ahead and they know exactly what to do for testing. And so everything I just went through is the present state of genetics, right? And to understand the present, you have to know what happened in the past. So what if I already had negative genetic testing? I have patients tell me this all the time. Well, it kind of depends on the year performed and how comprehensive it was. So on this timeline, this is specific to BRCA. So in 94, 95, that's when it was isolated. So clinical genetic testing for BRCA is actually a little bit newer than many of you might have thought. And so one thing that happened that was very important was around 2012, 2013. So in 2012, Myriad Genetics, many of you might have heard of that, they actually tried to say that they could patent genes. And the Supreme Court actually said to Myriad, you actually cannot patent genes. These are not yours to own. You don't own these. And so they said, you do not own a patent on these genes. And when that happened, that allowed other labs to open up. At the same time, our technology improved. So prior to that time, we were able to do stepwise testing, which I'll go through in a minute. We used something called Sanger analysis. And now in 2012, 2013, we were able to do next generation sequencing, which allowed us to look at more genes at one time and have a thorough look at it. And this is where the gene panel was created. And gene panel means that we're looking at just a group of genes related to a specific cancer or a group of syndromes. And so when we look through this, to think about that Sanger analysis I mentioned, so what genetic testing is doing is it's reading through these genes like a book. If we think of these genes like a book, we have 2 copies of all of them. We're trying to figure out if the end of the story is different. And so sequencing means we're reading through every single letter on every single page, front and back. So you can see here as the red changes. There is a second group of analysis that was done separately than the sequencing called deletion duplication analysis. So this looks at large numbers of letters that are missing or added, thinking of this as the paragraphs or the chapters of the book to see if there's changes at the end. And so some of those, depending on the year you had testing, that might not have been done for all of the genes that you were evaluated for, especially if it was before 2012. And then are there other genes related to cancer in the family? If you've met with me and if you've met with one of the docs that we work with, he always makes this joke. It's a very interesting metaphor, but it makes a lot of sense. He always says, you know, if you met with us back at this point and then you call us, 5, 10 years down the road, we will supersize your fries. So patients who've met with us because there's ovarian cancer likely had just genetic testing for BRCA or BRCA. However, there's other genes that are associated with ovarian cancer that patient or family might not have been tested for. And so we can go ahead and update your panel as years go on. I also have lots of patients who tell me, I did 23andMe. My family did 23andMe. Isn't that the same thing? So this is called direct-to-consumer testing. This is when testing is ordered by the patient without a healthcare provider, and it is never a replacement for clinical testing. So I went to the 23andMe website and read the fine print. If you read the fine print, on the right side, it talks about what type of DNA analysis does 23andMe do. It talks, what I underline here is that it looks at certain genetic variants in the genome, a process called genotyping. If we go back to our book analogy, what that does is that it actually looks at 3 different letter changes in the entire book. That's not comprehensive. The clinical testing that we do, again, looks at the entire book in its entirety. On the left side here, it talks about the specific BRCA variants that it says it tests for. These specific 3 variants that are listed here are ones that are seen more commonly in the Jewish population. If you are Ashkenazi Jewish, that test actually might be okay. But what this test does is it markets itself like it's a good test. It does a full BRCA analysis, and it does not. They include this on their website. We do not test for all possible variants. More than 1,000 variants in these genes are known to increase cancer risk. They look at 3. This test does not include variants in other genes linked to hereditary cancers. So again, if you did this test because there's breast cancer in the family or ovarian cancer in the family, we actually are not doing a full analysis of your inherited information. And so what does the future hold? I think that this slide should actually say, what is the current research of cancer genetics? The answer is likely polygenic risk scores. So poly means many, genic means genes, so many genes. What I just reviewed is one gene that is not working that automatically leads to an increased risk of cancer. And so these are not yet routinely used by healthcare professionals because there are no guidelines for practice. And again, it's still in the research phase. So the information about this is still research-based. It is not available for clinical use. So what we call that is the clinical utility is not there yet. But these, again, will always be probabilities. They are not certainties. And so what this does is it looks at, what this does is it compares those individuals that have a disease versus ones that do not. So if we think of cancer, so the more variants that we see that are seen in more individuals that have disease, it's likely a higher increased risk, and vice versa. So the less you see it, it's likely associated with a decreased risk. And so the idea is that we combine these polygenic risk scores with other factors such as diet and lifestyle, stress levels as an example. This might give us a better idea of how to understand your risk more outside of just regular genetic testing or using family history to make our recommendations. And so the goal of all of this, of course, is to then say, how can we be proactive? What steps can I take to then help reduce my risk as much as possible, prevent it in the first place, or catch it at the earliest stage possible? And so one thing I also like to point out is the health disparities. So this is a graph from the genome.gov website that shows the variation among ethnic groups. So the vast majority, as you can see, is the European population. So once this does become clinically available, it's likely only to be used in the European ancestry populations. There is not adequate information for other populations at this point in time. And I think this just highlights the historic lack of diversity in genomic studies in general. If we go back to that inconclusive type of result that I mentioned earlier in the presentation, with the lack of information in different populations, it's still unclear how often those variants are downgraded if you are not European ancestry. And so this, I think, just highlights the health disparities that exist in health, in genomic studies in general. But I am hopeful that polygenic risk scores, as more information becomes available, this is kind of the next phase of cancer genetics risk assessment from an inherited perspective. And then how do I find genetic counselor? I'm at Northwestern. All of you are welcome to come and meet with me. For individuals who have relatives that are outside of the state or different institutions, you don't know where to start, going to aboutgeneticcounselors.com, there is on the left side, there is this slide that, or the screen that pops up, how to find a genetic counselor. On the right side just shows exactly how you search for it. You can choose by in-person, you can choose by telehealth, the specific state, you can choose by the type of specialization, and all the genetic counselors that are listed in your area would pop up. And that's the end. I'm happy to take any questions.
Thank you so much, Brittany. That was absolutely fascinating. So thorough. I am going to defer the question and answers because we went over and I want to make sure
Sorry.
we keep Hannah
Sure.
on schedule. No, that's absolutely okay. Knowing that we can reach you, I'd be happy to send those to you and we can include them on the recording if people want to go back and take a look at them. You actually answered the question that was posed in the last chat. So I really appreciate that.
Yep,
It
no
was
problem.
very exciting to hear some of the new advances, and we appreciate you taking your time to be with us tonight.
Thanks so much for having me.
Thank you. Bye now.